Today, we will be talking about a hysterectomy specimen for a cervical carcinoma and an incidental submucosal leiomyoma.
Thanks again for joining us. So without further ado, we'll show today's specimen.
What is this specimen?
Okay, great. It seems like most of you got the right answer. So what we have here is a simple hysterectomy with a bilateral salpingo-oophorectomy. But we'll go through the other answers and explain why they do not apply to this specimen. So our first answer was a simple hysterectomy. That would include the corpus of the uterus and the cervix as well, but a simple hysterectomy doesn't necessarily contain both the fallopian tubes and ovaries. For subtotal hysterectomy, that would be a hysterectomy without the cervix. In a radical hysterectomy, you would expect parametria, which is soft tissue at the lateral aspects of the specimen, and also you would expect to see a larger rim of vaginal cuff along the circumference of the cervix. Okay, let's do some discussion now. Can you tell me what are some benign reasons of why we would receive a simple hysterectomy with a bilateral salpingo-oophorectomy specimen? Okay, great. Seeing some good answers. So adenomyosis.
Wonderful. Prolapse.
Fibroids, endometriosis.
Great answers. Yes. Prophylaxis. I think I saw one there.
Yeah.
And for clarification, can someone spell out what AUB is? Thank you. Just a reminder, folks, we have quite a varied number of participants, anywhere from medical student trainees all the way to staff. So we're going to try and cater information to every group there.
How about infectious reasons? Does anybody know what it's called to have an infection within the uterus? Okay, PID. Yeah, endometritis. Great. Also not very commonly seen in humans, but you can have something called pyometria, where you have a collection of pus within the uterus. It happens, but it is very rare, but it can be due to a stenosed cervical os. Okay, so now that we've covered a majority of the benign reasons, what are some malignant reasons for a total hysterectomy specimen? Great, endometrial cancer, ovarian cancer, hyperplasia, Lynch syndrome, so going with our prophylaxis.
Thank you. I was waiting for that. Yes, and cervical CA.
Yeah, so I think we touched upon the major ones for malignancies. Before we go on, we'll go over the anatomy of the uterus and how you would orient these specimens if you receive them in the lab. So our uterus is comprised of a corpus, which is the superior portion here, and the cervix or the neck. The cervix usually houses our exocervix. Centrally, you have an os, which in this case, if you can see that in the camera, it is a little bit dilated and slit-shaped. On either side of our uterus, here we have right between my forceps are the fallopian tubes, here and here, and ovaries. When you have tubes and ovaries, it's easy to orient these type of specimens. So from anterior to posteriorly, you see from the top view here, you're going to have your round ligament, most anterior, then your fallopian tubes, and your ovaries. Alternatively, on the anterior surface, you have this peritoneal reflection here, and it is higher on the anterior surface than posteriorly. So I'll turn this over to the posterior aspect. We can see here that the peritoneum is a lot lower and it sometimes comes to a point. So on the inner surface of the uterus, we usually prep these by sticking blunt end scissors into the os and then cutting on the lateral aspects to expose the endometrial cavity. Our endometrial cavity is this triangularly shaped region here, which I'm outlining with my forceps. More inferior is our endocervical canal and our endocervix and lower uterine segment. Okay, and so looking within the endometrial cavity of the specimen, you can kind of see this lobulated and protruding thing here. So what could this be? Great. So I'm seeing a lot of leiomyoma here. Someone said it's still, yeah, submucosal leiomyoma. Great. Endometrial polyp. Okay, good. So we have fibroid, polyp, and endometrial carcinoma. Great. So yeah, those are kind of the major things that we would think if we were to see a mass within the endometrial cavity.
We also have some votes for a sarcoma.
Sure.
And gestational trophoblastic disease even. Yeah, I guess it could be, but usually you have some more pregnancy-related changes and some more cystic structures.
In that case, the uterus would still be postpartum and be rather large compared to this one here. So we're getting some great answers. There could be many benign and malignant reasons why this specimen could have been removed. The thing about gynae pathology is it can be very subtle. And this is when history becomes really important. So it's always important to check all your history, past biopsies. We're going to come back and focus on the cervix a little bit more. We can see that there is this area here that is really congested and it looks a little bit ragged. What could congestion on the cervix be from? Great, yeah, prior definitely an option. So anything that would disrupt this area could be previous biopsy or a leap. So that's always a good thing to keep in mind. However, speaking on cervical cancer, what type of resection would you expect to receive with a cervical cancer specimen? Vaginal cuff, great. Well, it depends on the clinical stage for sure. But usually with cervical cancers, you do expect to receive a radical hysterectomy that tends to have vaginal cuff and parametria. But we're not seeing that here.
Sometimes you can get just a trachelectomy.
I think we'll just continue on this cervical cancer discussion. What do we call the precursor lesions to cervical cancer, right? LSIL, HSIL. For people that don't know, it's low-grade squamous intraepithelial lesion and high-grade squamous intraepithelial lesion, AIS, great.
Basically, any of the precursor lesion. You can also have glandular lesions that are pre-malignant in the cervix. And again, we're just trying to zero in on that because I think from what you saw from the cervix is that that does not look normal. Often when you have a hyst with the cervix, you usually have a very shiny thing. But again, there's a disconnect here, right? Because as everyone pointed out from the chat, for a cervix CA, you usually have a rad hyst, which means a lot more parametria and vaginal cuff that's removed. So we will proceed along those lines of the discussion.
And I think we can go into maybe our second question.
Sure. Which of the following are cervical cancer risk factors?
Great. So the results are kind of spread out, but the number one chosen answer was HPV 16 and 18 infections. That's great. That is one of the major risk factors for cervical cancer. HPV 16 accounts for 60% of cervical cancer cases, while 18 accounts for another 10%. And so for the other questions, the only two of these that was not a risk factor were HPV 6 and 11 infections. So those are the ones that are usually associated with usually more low grade. And having a first pregnancy at age 25 and older, having your first pregnancy at age 25 and younger actually increases your risk of cervical cancer.
So just to reiterate, the high risk HPV, 16 and 18 serotypes, smoking is for sure a big one. HIV or any immunosuppression are big answers. And yeah, you did say first pregnancy, right?
Yeah, so the first pregnancy at age 25.
So it's the multiplarity that's not an issue, and the low risk serotypes.
So now we'll talk about how we would approach grossing the specimen. As is standard for all institutions, you're going to measure your uterus in 3 dimensions: superior to inferior, anterior to posterior. We tend to measure our cervix in 2 dimensions. So you can usually do anterior to posterior, medial lateral. And then for tubes and ovaries, we'll measure the tubes in length and width and the ovaries in 3 dimensions. For the internal cavity of the uterus, we will measure the length of the endocervical canal and then give 2 dimensions of the endometrial cavity. And so once we have all those measurements, we'll start by serially sectioning through both halves of our uterus here. And then once we've sectioned through it, we're able to give a thickness of both the endometrium and the myometrium. Yes, and weight, of course. You can never forget the weights. So at our institution here, we weigh all our uteri fresh. Does anyone weigh their uteri fixed at their institutions? Always. So you can see there's always a lot of variation of when we get our weight, but weight is always very important.
Oh, and some don't weigh.
Very
Interesting.
interesting. Okay, so we'll approach this specimen as if we're doing a cervical cancer. How many of you amputate the cervix and pin it out starting at 12 o'clock? When I say 12 o'clock, that means the most anterior aspect of the cervix is designated 12 o'clock, as if you're looking at the face of a clock. Some do. That's good to know. It's only
So-
if the os is big enough. There are some, I guess, limitations to that method, but that is like a method that a lot of people commonly do.
We'll go over that a bit more. I have a PowerPoint showing what it means to
Mhm.
pin it out and
Yeah.
do a clock face.
We would describe this kind of ragged and congested area as our lesion, and then you would want to give measurements to your vaginal cuff margin, which is right here. For us, we will designate the most anterior point as 12 o'clock and then radially section each quadrant. By radially section, we mean that we wedge the cervix. We'll section the cervix like so. And we usually end up submitting clockwise, and we'll designate 4 quadrants. So we'll submit from 12 o'clock to 3 o'clock, 3 to 6, 6 to 9, and 9 to 12 again. Okay, and then we would examine the remainder of the endometrial cavity, submitting any fibroids or polyp, and then just doing representative of the endomyometrium. Okay, and then so our fallopian tubes and ovaries. So I think we can go into our third question.
So how should we treat the ovaries and fallopian tubes in these cases of suspected cervical CA?
It's a very interesting spread. So the correct answer for this is typically representative of both. I know there's some institutions that like to just submit the fimbria in toto and then representative of the tube and then representative of the ovary. But again, I know this can be institutional dependent. Some institutions prefer both tubes and ovaries in toto for every gynecological cancer they receive. But if you're going by the protocols and what's warranted, typically only representative is needed for cervical cancers.
Caveat again being that check your institution SOPs. Sometimes it can be pathologist dependent too.
Okay, so it is a little bit strange to be looking at this total hysterectomy without parametria, but we do have a diagram to show you what are the steps to take for grossing a radical hysterectomy for cervical cancer.
We have a question in the chat there.
Oh.
What do you think?
Would you only really section the cervix in cases when you suspect a cervical malignancy? Yes. So if I suspect that there's a cervical malignancy or if the patient has a prior history, even if she didn't have a prior history and the cervix looks a little bit strange to me, I would just go ahead and radially section the cervix and submit it in toto.
I don't think anyone will fault anyone for adding more tissue. If you are suspicious of something possibly worse going on, it's better to oversubmit rather than having to go back and figure out where you were and submitting there.
So we'll just show you the steps for grossing a cervical cancer with received as a radical hysterectomy. This is a nice diagram from Springer's surgical pathology dissection. You can see here that the parametria is this kind of soft tissue on the lateral sides of the paracervical margin. If this was a radical hysterectomy for cervical cancer, we would transect both the right and left parametria and refer to them as such, right and left. Additionally, we would section through that parametria and submit it in toto. The vaginal cuff margin, so we can see on the diagram, the vaginal cuff extends maybe about half a centimeter past our exocervix. You tend to get within your radial sections, but if your vaginal cuff is very large and would take up too many blocks to submit entirely, you typically submit the vaginal cuff nearest to your lesion and the remainder can be submitted en face. What we mentioned before, the differences in prepping these specimens and grossing these specimens, some institutions can opt to transect the cervix off and then pin it out. This diagram is really nice because it can show you all the faces of the clock. And sometimes as well, if your cervix is big, it actually makes it easier to gross as well because you're not having to wedge your cervical sections as much.
This is just to highlight in terms of the clock facing, starting anteriorly and then moving around the clock hours and then pinning the whole thing out that way. Just wanted to remind everyone of the different risk factors associated with the precancerous lesion. We talked about those high risk and low risk HPV serotypes. And because of that, there are these precancerous squamous interepithelial lesions associated with B and their serotype. And they are divided into LSIL and HSIL. And this is a common question in terms of how often they can regress, persist, or progress into something worse. And these are the most common numbers that are quoted, the 60-30-10 rule. LSIL most of the time will regress, some will persist, and very few will progress. HSIL is the one that tends to persist a bit more, and then the big risk for the high-grade squamous interepithelial lesion is the progression to invasive carcinoma, and that happens roughly about 10% of the time. Just a reminder for everyone about cervical cancer staging, and that we actually do have very complex, in my opinion, size cutoffs with respect to cervix. And this is part of the reason why we do the clock phase, especially in this case where it was really hard to see if there was anything macroscopic or grossly visible. We just see areas of congestion as opposed to a mass lesion. Chances are we're dealing with something in the PT1 stage, or at least a microscopic stage of invasion. So just keep that in mind, that there's the different levels of the T stages that are mostly dependent on confinement to the cervix, and then eventually whether it will involve the lower third of the vagina or extending beyond the pelvic wall, including causing hydronephrosis. So you can imagine the way that cervical CA tends to progress into a bad disease is them kind of going down and involving areas, organs outside the pelvic wall. But more simply, I like to simplify. I'm a simple guy. Just thinking about it from the FIGO staging, where 0 is CIS, carcinoma in situ, or HSIL. And then just think of the landmarks here, the carcinoma confined to cervix, extend into beyond the cervix, but into the uterus, but not into the lower third or pelvic wall. And then you've got stage 3 being the lower third and pelvic wall, and then 4 involving other pelvic organs. That's how I remember these things. The role of the pathologist really is confined in the PT1 stage and T2 to some extent, where you do have these measurements that are given, mostly in the PT1, I should say. So if you do see something in terms of any lesion, really, not just the cervical cancer, always measure. And in this case, to the nearest 0.1 of a millimeter, just so you can be a bit more sure. I think we'll do our next poll. It's a little bit of fun. What does FIGO stand for? It is the authoring body for a lot of the gynae oncology management and staging.
Okay, so it seems like we tricked you with this question. FIGO actually stands for the International Federation of Gynecology and Obstetrics. Good for you that got it. Originally French, which is why the FIGO doesn't exactly line up with its translation.
So can we go back to the specimen and talk about the other pathologic finding in this?
Yes.
The more obvious one.
Yes, the more obvious one is this lobulated firm tan nodule in our anterior endometrial cavity.
Do you think we can introduce a cut?
If we can definitely do that.
I think people have mentioned some potential candidates, right? The most popular one being a fibroid. And just because we're trying to be opportunistic as much as possible here, if you haven't seen a fibroid, it has a very distinctive surface cut to it. Hopefully we will be able to see. Again, always safety first when it comes to these things. Dealing with very sharp things.
Very nice.
Okay. What do people think? People still okay with submucosal fibroid?
All right, so what are we thinking? Cystic degeneration.
Okay.
So just a sarcoma?
We'll put a pin on these thoughts and ask a full question here. So which of the following is not a classical degenerative change in leiomyoma that can be seen grossly? Leiomyoma is probably one of the more common specimens that you'll see in a surg path lab. Leiomyomas can come in many different shapes and forms. So it's a good idea to be comfortable with which ones are within the realm of quote unquote degenerative change, i.e. non-neoplastic change. So all the other ones, edema, cystic change, calcifications, ossification, fat necrosis, and red degeneration. These are all degenerative changes that can be seen in the leiomyoma. Ulceration, not common, and in fact might pretend for something else. We see one of these changes in this mass, which, as
Mhm.
someone had pointed out, was cystic change.
Yeah, so we can see that right there. Cystic, it's a little bit gelatinous. And we actually have multiple pockets of these gelatinous cysts kind of all interspersed throughout this mass here. So great. Whenever you have a larger fibroid in your uterus, you always want to look out for any signs of necrosis, which can appear as chalky yellow areas, or any areas that are overtly hemorrhagic. For grossing the specimen with what we think might be a fibroid, you would still do your initial measurements of the specimen overall. And you would definitely measure this mass in 3 dimensions and describe how it is in relation to the endometrial cavity. In this case, we would say that it is disrupting the left anterior endometrial cavity, and you want to also describe the border between your nodule and the cavity as well. If you are suspecting that this is possibly a malignant nodule, additionally, you'd want to measure the nodule to your nearest paracervical margin and to the vaginal cuff margin. In terms of sectioning, regular fibroids, it would just be a couple representative sections, and you want to show any areas that are degenerated. If you're suspecting something that might be a malignancy, probably opt to do maybe 1 per centimeter.
Right. Not that we're suspicious of that, but just to get to that question, there's no fat in leiomyoma classically. Absolutely, there isn't. It's a smooth muscle proliferation. That being said, though, metaplasia is very common in smooth muscle tumors, specifically in this case, and that's what actually happens. That's why you get the ossification, right? Anything mesenchymal can potentially transform into any of them. You get some cystic change related to that. Leiomyomas is probably one of the more common specimens that you'll see, and it's good to know the different gross appearances of leiomyoma. There's a question, could this be an adenomyoma? So let me answer that question by turning the question back. What's the classical gross appearance of an adenomyomatous uterus? Yeah, globoid. They're bulky with this lacy, trabeculated look. They're globoid. It's deep within the myometrium, and it's not as very whirly or white. Never say never, of course, and that's why we go through submitting these things under the microscopes. But just from the location of this thing, the cystic change, I think it's all in keeping with a submucosal leiomyoma. And then how does calx and ossification grossly differ visually? Good question. I often think that calcification is more punctate, whereas ossification is a bit larger.
Yeah.
Thank you for a very lively conversation. I think that's all we have for you today. A simple hysterectomy with a TAH BSO. We went through some features and cervical CA, and we also had some discussions about leiomyoma and the many different phases of leiomyoma. So yeah, thank you so much. If there's any questions, please let us know.